Hello, hello.
Hello.
Hi, sir.
Okay, Dr. Aditya. Good evening to you. So, you, if you can, are you not able to open your video? Because you can close that window afterwards. That's fine. Yeah. Hello. So, this would be our first class in the
Yes, sir.
abdomen chapter. You have asked, requested for abdomen. मेरी आपको वीडियो दिख रही है ना? I will change my slide. 1 second. Now I would be visible clearly. Okay. So yes, the topic of our discussion is dysphagia right now. I have written it someplace for the lecture. Shall we start? आप मेरे साथ साथ लिखेंगे.
Yes, sir.
ऑफ कोर्स आपको पीडीएफ मैं प्रोवाइड कर दूंगा. आई थिंक डेमो क्लास का कोई इशू रह गया होगा, वो फाइल ओपन नहीं हुई होगी. बट फ्रॉम दिस पॉइंट ऑनवर्ड्स आपको पीडीएफ मिल जाएंगी. ओके. बट आई वुड स्टिल लाइक कि आप राइट करो मेरे साथ साथ, तो आपको बेटर अंडरस्टैंड होगा कंसेप्ट.
Yes, sir.
ठीक है. ओके. So yeah, dysphagia. See, why I'm choosing dysphagia as a first topic. The reason is you have requested for abdominal examination or abdominal clinical postings about abdomen.
Yes, sir.
In abdomen, in medicine especially, there are some chief complaints for which patient come. Okay. There are 2 to 3 major complaints in medicine and similarly 2 to major
Yes, sir.
complaints in surgery. And they all are mixed together. Ki we are very confused ki okay, this is a medicine case or this is a surgery case. So we don't know how to take the history and how to classify it, because most of the diseases, as a GIT as a system, if we take, most of the diseases management starts with medicine department, and most of the complications are dealt by surgery department. Okay, when the patient comes to OPD, the patient will come to OPD of medicine mostly, and then
Yes,
it
sir.
will be referred to surgery. If any complication of any disease, whichever the disease is, whether it is esophageal cancer, carcinoma, or not oncologically, or GERD, or any other case, minute bleeding, blood in stools, hematochezia, hemoptosis, any major complaint which for which the patient comes, they will mostly first come to medicine OPD. So we have to, as far as GIT goes, so there is a very integrated approach we have to take with medicine and surgery. If I classify into basic major 3 parts, why a patient comes or to OPD, the first part is dysphagia. Most of the patient have a complaint of dysphagia. The other part, for the other complaint they come is UGI bleed or LGI bleed. I'm not saying these are the diseases, but what they lead to. The major complaint is melena or
Correct.
hematochezia.
Dyspepsia and dysphagia, same.
Hello?
Is dyspepsia and dysphagia same?
Yes, yes, dysphagia, dyspepsia, that is the PUJ, na? PU, peptic ulcer. And peptic ulcer will cause obstruction. What is the fate of an ulcer? Ulcer will get complicated and can get perforated or can get bleed, or it can stenose and it will lead to obstruction. Any of that complication, that patient becomes a surgery patient. Before that, it is of medicine department patient. You get my point?
Yes, sir.
So we will have an integrated approach regarding the disease and regarding the symptoms. So first one, I am starting with dysphagia. So I would like to know, do you know what is the definition of dysphagia? Exact definition, which you would answer in Viva. There are two terms, dysphagia and odynophagia. What is the difference between these two? Hmm. आपको पढ़ाया गया होगा. You have
Difficulty swallowing,
okay difficulty
swallowing.
in swallowing, and then odynophagia is this is difficulty in swallowing. That is correct. This is the right definition of dysphagia. The odynophagia is painful swallowing, but it is any swallowing which is painful to us. That symptom is called odynophagia. One thing is dysphagia, one thing is odynophagia. If there is pain in swallowing something, of course that is a difficulty also. You see my point? The thing is odynophagia always comes with dysphagia, but that doesn't mean dysphagia and odynophagia are same terms. Clear concept?
Yes, sir. Yes, sir.
And an example of painful swallowing or odynophagia you need to know is eosinophilic esophagitis. Esophagitis means eosinophilic means allergic origin, which may be due to IgE mediated or allergy mediated. Esophagus, the part which is involved, anything itis beyond a part is inflammation. Allergy related esophageal inflammation will lead to painful swallowing as a symptom. Okay, so this is one of the example. Many kind of esophagitis mostly present with odynophagia. Rest other conditions because dysphagia is a very broad term. So before getting into dysphagia, I would like to know, do you know the physiological aspect of swallowing? If you have that covered in the basics, we can move ahead. Or I will just share it as a summary. Physiology of swallowing. There are three phases. आपने पढ़े होंगे. You have read it about this. Oral phase, then transfer phase. Or transfer phase is also called as pharyngeal phase. And the third one is esophageal phase. Should I get into more detail in this or you have read it before?
Sir, I have some idea before.
You have some idea before? Okay. So I will just have a summary then. The thing is, I will discuss oral phase first. Oral phase is when start of the GIT start from the mouth, from the tip of the incisor. GIT examination is started. When they start, they say, ki, okay, you have to look for upper GI. You start your examination from the mouth itself. Esophagus से start नहीं हो रहा. Our problem doesn't start from esophagus. Our problem starts from the lips itself. If there is an aphthous ulcer in lips, that is the upper GI problem. That will come in GI. Okay. So oral phase. The physiology of our oral phase revolves around food motion from mouth to hypopharynx. That is oral phase. Then pharynx phase from hypopharynx to esophagus. कौन सा junction? Upper esophageal sphincter is pharyngeal phase, and esophageal phase is upper esophagus to lower esophageal sphincter, and then to stomach. This is the pathway. Why I'm giving you the summaries from mouth to hypopharynx. Okay, from mouth to hypopharynx, there occurs two mechanisms. First is mastications. Mastication, that is chewing of the food, which is required. The other is bolus push. You have chewed the food, now you have to push the food. Who will push the food? That is a function of tongue. Okay, these are two parts. Mastication is supplied by which cranial nerve? Can you answer? Mastication and muscle of
Uh,
mastication. You will read it. Which cranial nerve?
Trigeminal. Trigeminal nerve.
Which? Trigeminal nerve.
Trigeminal
Okay.
nerve.
That is fifth cranial nerve. Yes, you are right. And tongue bolus push is supplied by, this function is done by hypoglossal
12.
nerve, which is
12.
12th cranial nerve. In any case of fifth cranial nerve palsy or 12th cranial nerve palsy, when these functions don't occur, they will lead to dysphagia. They will not perform their function, physiological function. Am I right? You get this?
Yes, sir.
In pharyngeal phase, what is the work in the pharyngeal phase from hypopharynx to esophagus? See, there are two openings. There are two openings. One is trachea, and one behind it is esophagus. What is the work? How the food gets pushed? You need two things. One, there should be a closure of trachea. Trachea lid should be closed. This lid is epiglottis. You have heard it in ENT, I guess. This epiglottis should close the trachea, and this upper esophageal sphincter should relax. When these two things happen, then the food particle will have a direct pathway and enter esophagus. Is this clear?
Yes, sir.
Okay. See, the supply of epiglottis is cranial nerve 9th and 10th. Glossopharyngeal nerve and vagus nerve are responsible for supplying the epiglottis, and they will lead to closure of epiglottis or the closure of trachea or closure of larynx, laryngeal inlet closure. Similarly, upper esophageal sphincter is supplied by also vagus. So, if glossopharyngeal nerve or vagal nerve are some kind of paralysis, there is cranial nerve damage to them, then also they will result in dysphagia, and it will be dysphagia of pharyngeal phase. Okay, I'm just
Yes, sir.
discussing the neurological cause because it is easier to do them in physiological discussion. Now, upper esophagus to lower esophageal sphincter. The food is here. Lower esophageal sphincter and upper esophageal sphincter. See, the thing is, esophagus nervous supply is not by cranial nerve. I know it is by vagus somehow, but the supplier tissue or plexus is called myonteric plexus. Have you heard about this plexus? Meissner's plexus, myonteric plexus. And this particular junction, lower esophageal junction, is supplied by the ganglia, which is of thoracic region. Myonteric plexus is also known as, what is the other name? Can you tell me?
Uh, Orbex.
Or back plexus. Very good, man. Very good. So yes, what does this plexus have function? This is function of peristalsis. So this is a little bit summary of how the swallowing occurs and what are the important points. I am not going into the detail or the motion of how the larynx will pull up and forward. We won't be discussing that. That is an ENT topic. Okay. यहाँ तक any problem till this point?
No, sir.
Okay. Let's move forward. I will discuss now these phases, whether it is oral phase, whether it is pharyngeal phase, whether it is esophageal phase. These two are clubbed together as oropharyngeal dysplasia. I am putting D here. If there is some kind of defect here in oral or pharyngeal, it is classified as oropharyngeal dysplasia, and esophageal dysplasia as a different identity. We discuss it as other thing. Okay, we divide it as two. because they have a different kind of profile to each other. So oropharyngeal dysplasia can be due to neurological causes, as we have seen cranial nerve 5th, 12th, 9th, 10th. If they are damaged, then they will result in neurological cause of oropharyngeal dysphagia. Can you give me any example in which any example of these nerves involvement and their palsy? Any example of a disease?
Bell's palsy.
Bell's palsy. Bell's palsy is for seventh cranial nerve,
So,
na?
yeah,
Okay, that's fine. I'll tell you one important. Okay, I'll then explain it in thoda detail. Bulbar palsy. Have you heard about bulbar palsy?
no,
Bulbar
I don't
or
remember.
okay, I'll tell you. Pseudo bulbar palsy. I'll give you a little brief. Have you heard about brainstem? What is a brainstem? This
Medulla
middle brain,
oblongata and pons.
no middle brain, pons, and medulla oblongata. These all three forms brainstem.
Brainstem.
Okay. Now the thing is, ki if you look at this drawing, it will look like a bulb from above, and it is getting lit. This look like a bulb. This shape. Hello. This look
Yes,
like
sir.
a bulb to you. So yes, brainstem is brainstem. We call it brainstem. Brainstem also known as bulb in anatomy because it resembles bulb. Any brainstem damage or brainstem palsy will be called as bulbar palsy. That is fine.
Yes,
Now,
sir.
when I talk about brainstem, all the cranial nerves. See, there are 4 cranial nerves in each compartment. 4 in middle brain, 4 in pons, 4 in medulla oblongata. The numbering goes from 3 to 12. This much anatomy we know.
Yes, sir.
Cranial nerve 3, 4 in middle brain, 5, 6, 7, 8 in pons, 9, 10, 11, 12 in medulla oblongata. And this medulla oblongata is a high risk area for bulbar palsy because 9, 10, 11, 12. 9 and 10 and 12 are there for dysphagia. 9, 10, and 12. You get my point?
Yes, sir.
Okay. So there is a triad of bulbar palsy because it's a neuroviva question. They ask, what do you know? What is bulbar palsy? It's a neurological case. Kabhi bhi if you are in a hemiplegia, hemiparesis case, na, you will get this question, what is bulbar palsy? So I am making it clear. That's why I am explaining so much. What are the triad? What is the triad of bulbar palsy? They ask, what is the triad of bulbar palsy?
Bulbar.
Bulbar palsy. One thing you know what is dysphagia, difficulty in swallowing. This means difficulty. Phagia means swallowing. The other thing is dysphonia, or it is also known as hoarseness, which is due to ninth cranial nerve damage. The third is dysarthria. Okay, arthria. Why I'm saying arthria? It is why, because you cannot modulate your laryngeal musculature. The larynx cartilage का जो movement है, that is also governed by vagus and glossopharyngeal nerve, na? If that get damaged, so your larynx will not move. That is called as dysarthria, difficulty in articulation of laryngeal muscles, laryngeal structure. So this is the triad of bulbar palsy. Very repeatedly asked question, very viva friendly question. They will ask you this in CNS presentation or in dysphagia. You have to learn this. Okay. Any doubt here?
No, sir.
So there are many diseases which can cause bulbar palsy. One example is motor neuron disease. or you will learn it as amyotropic lateral sclerosis in neurology. See, the other thing, other neurological cause can be, you have heard of this disease, myasthenia gravis.
Yes, sir.
Have you heard about this disease? Why
Yes, sir.
myasthenia gravis? Myasthenia gravis can also present with bulbar palsy. You know how? Myasthenia gravis will mimic bulbar palsy. How? In myasthenia gravis, there is weakness of muscle, generalized weakness of muscles. The first is palpebrae superior, which will lead to ptosis of the eyelid, and then it will go down and cause the weakness. The second structure which will be weakened is our mouth and pharyngeal muscles. That will lead to dysphagia, dysphonia, and dysarthria. So it can also cause dysphagia, myasthenia gravis. Third feature you can have a DDX as is if there is a stroke or brainstem. What is stroke? You have any idea? Stroke क्या होता
The
है?
sudden
Abrupt ischemia. Yeah, vascular supply block होगी brainstem की. We have blocked the supply of brainstem. That will lead to what? Ischemia. That will lead to death of that part, and that will lead to bulbar palsy symptom or pseudobulbar palsy symptom. Stroke of brainstem. Also, other neurological cause which can result in dysphagia is Parkinson's. Yes, Parkinson's can also cause dysphagia. This list is important. Rest are not. There are other
that
classification.
one second M&D full form, sir. That M&D. Neurological
MND. This
ALS, amyloid.
MND is a motor neuron disease in which mainly the motor neurons which are getting out from the brainstem and supplying the other glands or muscles, they are blocked. See, there are two types of diseases in neurology. One is sensory output, sensory defects. One is motor defect. Okay, sensory defect is going from, one second. You can see me now. My video is visible. My
Yes, sir.
screen visible, not my screen. My video. You
Yes,
can.
sir. Oh, your
Okay.
video
Yes.
goes with only the notes is visible.
Okay. You are, maybe you are watching on your phone. That
Phone.
that may be the reason. On tab it is visible. Okay, that is fine. In motor neuron disease, just listen. There are two pathways. Let's say this is brain. There would be ascending pathway. If there is damage here, that will lead to sensory diseases. And there is descending pathway. If there is damage, that will lead to motor diseases. A group of diseases which are due to various level of defects in descending pathway, we classify as motor neuron disease as a huge class, in which one of the example is amyotropic lateral sclerosis. Very famous scientists have it. Have you heard about Stephen Hawking?
Yes, sir.
Stephen Hawking, he can't speak, he can't eat,
Yes.
he can't modulate. Stephen Hawking has got bulbar palsy as a part of his amyotropic lateral sclerosis. If this part is damaged, but his brain is functional, his sensory is functional, he can feel pain, he can think. That's why he what the hell will that guy do? He can only think. So he will think about universe and all the other things. He cannot move because his motor neurons pathways are defective. Okay,
Yes, sir.
so it's a very huge topic in neurology. We will discuss it later if the time permits. Let's move to anatomical. There may be few anatomical reasons for oropharyngeal dysplasia and for esophageal dysplasia. Neurological features may not be there because esophagus has got its own plexus. So nerve supply is not that of a issue. What may be the issue is the abnormality of this plexus or absence of this plexus or overstimulation of this plexus, anything related to this plexus may result in motility disorders. What is the classes? Motility disorder. Or there may be some kind of mechanical obstruction. Can you think of any mechanical obstruction which may stop the food from going inside? One example is esophageal carcinoma. If there is a cancer tumor in the esophageal pipe, will it let the food go down easily?
Awesome.
So that will lead to esophageal dysphagia. So this is the basics about dysphagia. I think we have acquired ourselves with a little bit basics of the dysphagia, how the three phases occurs, why they are important. Now we will try to treat a patient of dysphagia if he comes to OPD. Now I will move into the surgical aspect because there is not much discussion as a medicine person here. But for the sake of physiology and all other features, I have to do that. Second. Okay. This is the approach to dysphagia. Let's see a patient comes to you saying, I am a patient of dysphagia. He will not tell you, I am a patient of dysphagia. A patient comes and complains of difficulty in swallowing. He will say, I am having difficulty in swallowing. You will, in your thought process, you will think whether it is oropharyngeal dysphagia or esophageal dysphagia. Okay, oropharyngeal or esophageal. So you will ask questions as a history. When you are taking the history, you will ask questions. Mind you, I tell you, you can only ask 3 to 4 questions in any case. So you should carefully listen to these questions, which questions you need to ask for a symptom. If a patient comes with difficulty in swallowing, the first question you will think, you will not ask. You will think, I will make the question. Always consider it as esophageal dysplasia. Dysphagia. I don't know why I'm saying dysplasia. Dysphagia. The first rule of thumb is always take a patient of dysphagia as a esophageal dysphagia until proven otherwise, and we will prove other things. Okay, until the profile tells you. What is the profiles? If the profile of patient tells you, when you ask, okay, tell me more about that. When does the dysphagia start? What is the onset? And the patient tell you it is in the initiation. Okay, whenever I eat food, it occurs at the start. Starting saying I am feeling difficulty or I am feeling discomfort. Initiation of swallowing. Dysphagia is in which part of swallowing? Initial phase of swallowing. Or if asked, it is associated with nasal regurgitation. Does the food come back to you in the nasal pathway? Do you have any kind of choking sensation? Do you feel any foreign body sensation in the neck? In which part? You have to ask if you are feeling foreign body sensation in neck. Has there any kind of history of aspiration? You think you are eating something and you think you have a cough and the food get aspirated outside or maybe into lungs. That history will relate to dyspnea or other respiratory problems also. So if the profile of a patient says this, only this, then only we will consider it as a patient of oropharyngeal dysphagia. Understood? You
Yes,
have to
sir.
look for this profile. Okay. If anything else, He says, no, no, no. I don't have initiation in swallowing. I have something else. I feel discomfort when I eat food after some time. No, I don't feel nasal regurgitation. No, I don't feel choking sensation. So, what can he feel? I will write it here. What can he feel that will make sure, okay, this is esophageal type of dysphagia? One thing he will say that dysphagia starts after, sorry, dysphagia will start few seconds when I eat the food, few seconds after eating or after swallowing. That means the food has reached to the esophagus and now he is feeling difficulty. This is a common sense question, but you have to ask him. Okay. Second, you have a feeling of food getting stuck. At which level? At sternum. He will say, he will point, even he will tell ki, okay, sir, in my chest, I think my food is getting stuck. He will not say, Meri gardan mein, in my neck itself. Okay. So
Yes, sir.
that's how, if this is the profile, you will tell these are the questions that will lead to believe, okay, this is esophageal dysphagia. In OP dysphagia, what you need to consider as an examiner or as a person. OP dysphagia, I have discussed the etiology here. There can be neurological causes, there can be anatomical causes. For neurological causes, we don't have to do abdominal examination. This will become a neuro case. Get my point? This will become a neurological case. Anatomically, one important DDX or differential diagnosis you need to know is Zenker's diverticulum. Have you heard about it in ENT?
No, sir.
Zenker's? Okay. Zenker's diverticulum. This is your first differential diagnosis as a oropharyngeal dysplasia. This profile comes, you will suspect what would be the diagnosis? Zenker's diverticulum. Okay. I'll write few points of theory if you want me to. If you don't have the access to it. See, it is a false, let's write this. False pulsion. It is a false pulsion diverticular. What it is? False pulsion diverticular. Why it is false? See, a true diverticula have all the layers of GIT. If this is GIT, you know GIT has many layers in it. 5 layers in esophagus. Diverticula means there is some kind of outpouching. If this outpouching has all the 5 layers, then it will be true diverticula. If it is if it has got lesser layers than that, then we will call it as false or false diverticula. So Zenker's diverticulum is not a true diverticula; it is a false because it doesn't have 5 layers; it is a 2 to 3 layers only. And why I'm telling you pulsion? Because if this, okay, I will draw it again. 1 second. This will be like this. This is the esophagus, and it will be hanging like this. This is Zenker's diverticulum. What is the site of origin from where it gets out? That place is called as Killian's dehiscence. In anatomy, you have heard about Killian's dehiscence when you were learning about laryngeal muscles. Laryngeal muscles, superior constrictor, middle constrictor, inferior constrictor. In inferior constrictor, you have listened about thyropharyngeus and cricopharyngeus. In between these two, thyropharyngeus and cricopharyngeus, in between these two, there is a gap. This gap is called as Killian's dehiscence, and from this gap, esophagus may have a outpouching to outwards, which may be of posterior lateral in position. It will be backward and lateral position. This is called as Zenker's diverticulum. Is this clear? left posterior lateral position. In the midline, the
Yes, sir.
age would be more than 50 years. The patient would be an elder, most commonly male. If a 50-year male comes to you with the profile of initiation, okay, I am having difficulty in initiation. Yes, I am having nasal regurgitation. Yes, I sometimes feel choking. Then you have to look for Zenker's diverticulum. Is this fine?
Yes, sir.
If I have to write all the clinical features, the first one would be dysphagia. Okay, the first one would be dysphagia. That is the first problem for which the patient came to OPD. On further asking, he will say, ki, okay, my friends also tell me I have a very bad breath. Very bad breath is called as halitosis. Halitosis, why halitosis? Maybe it is due to dental enamel erosion. Because he has got very much history of aspiration or nasal regurgitation. The food may come back or the acid may come back and it will stick to teeth and it will lead to bacterial growth and the teeth will get damaged and it will stink. So halitosis. This may also be the complaint. Okay. If these two are the complaints, that will guarantee the diagnosis is Zenker's diverticulum. What to do? Okay. I am suspecting Zenker's diverticulum. How how will I make sure कि this is the diagnosis? After a profile of the patient is done, what would be my next step? My next step would be to do a barium swallow. Okay. I will ask patient or I will write in prescription. Okay, you go to radiology department and get me a barium swallow. Okay. On barium swallow, I will look at the image and the image will be like this on X-ray. This simple drawing which I have drawn, it it will be on X-ray. Let me check if I have the image. Yes, this is. Can you see the image?
Yes, sir.
So this is Zenker's diverticulum. You understand what I was saying?
Yes, sir.
I ordered the X-ray. This was the image that came. This was the output. So now I am sure this is Zenker's diverticulum. How I will treat? I will check whether it is less than 2 centimeter or where more than 2 centimeter. This is my criteria of treatment. If it is less than 2 centimeter, I will ask for myotomy. What is myotomy? Myotomy is I will divide the muscle. Which muscles I am talking about dividing? This thyropharyngeus and cricopharyngeus. I will divide it in between and then I will push this back. I will make a cut here and then I will push it back and then suture it afterward. If you are healing a pipe, then pipe get ballooned out. You get that content wapis inside and then you suture it. You get this? Myotomy.
Yes, sir.
If it is bigger in size, I will cut, I will do the myotomy, I will divide the muscle, and then I will do diverticulectomy. Diverticulectomy. Ectomy. Ectomy means removal. Okay. I will remove the diverticulum. I will put a cut here also. And I will take it out and suture this part. Okay.
Yes, sir.
Or I can do what? I can do myotomy with diverticulopexy. These are only fancy names. You'll just need to know the meaning. Or I can do linear diverticulotomy. This is the difficult. Linear means in a straight line. Diverticular means this diverticular. Esophagostomy. Esophago means this is esophagus. I will make a linear cut line, okay, and open it and share it. How I am trying to do this? Let's say this is the esophagus and this is the pulsion. I will With my forceps, I will push it down and then suture it. What will happen? This is like this. This will be like this. Okay. This get attached there. Further down in the line, this will get destroyed and they will join naturally. This will happen, and thus the esophagus will be same. Or if I don't want to do it in a surgery, I can only always send a stapler down there. This is my stapler, okay, and this is my stapler prong, and I will put the staple pin here and do the same thing here. These are the staple pins. When you do that stapling, we call it as endoscopic stapler. What do you call it?
Endoscopic stapler.
The name for this procedure we like to name is Dolman's procedure. Say, this is the esophagus, this is our stomach going, this is our pulsion. I will put the stapler here and get this here and then click, click, click. You understand how it happens?
Yes, sir.
Okay. This is as far as Zenker's diverticulum is concerned. And oropharyngeal dysphagia. We don't have to discuss much more about oropharyngeal dysphagia from this point onwards. Let us focus on esophageal dysphagia now, because that is our main goal. One second. You see, esophageal dysphagia occurs, I can say it is a peristalsis defect, because esophageal dysphagia, the phase of swallowing of esophagus, does the function of peristalsis. Am I right?
Yes, sir.
Okay. See, the peristalsis, if I have to peristalsis not working, see, peristalsis occurs in three phases. There is primary peristalsis, there is secondary peristalsis, and there is tertiary peristalsis. There are three waves in peristalsis. These are type of wave. This may be primary, this may be secondary, this may be tertiary. Okay. There are three type of waves occurring. Not the exact picture I want to depict. Let's say this is the primary wave. This may be secondary type of wave. This may be tertiary type of wave. So three different frequencies and amplitudes of waves are there in peristalsis. You need to know this. Primary wave, when the primary wave comes, when you initiate swallowing, when you put the food on your tongue, the esophagus starts contracting. Okay, to take the bolus down. When you initiate the swelling, primary wave is for to take bolus down. Secondary wave, it is normally absent. In a normal case scenario, secondary wave is absent. There is no secondary wave. If there is presence of secondary wave, that means it is a pathology or it is a disease. Okay. Tertiary
Sir.
wave is a wave of no significance. I mean, this wave is there, but it has no function. This wave is neither progressive, non-progressive, nor propulsive. Neither it is propulsing the food. Okay. So our main concern is with the primary wave defects. Simple. As I have told you, esophageal dysphagia can be due to two reasons. One is motility disorders. That means peristalsis defect. Peristalsis that means primary wave defect. These will be synonym in nature. Okay. Or the fancier name which all of us call it as functional dysphagia. What do we call it? Functional dysphagia. Why I'm saying functional dysphagia? That means everything, each and every structure is normal, but still there is dysphagia. You get my point? So that means there is some alteration in function, not the structure. Okay.
Yes, sir.
Till now, any doubt? We're in our story two, approach of dysphagia, and making a flowchart. This may seem some cumbersome to you, but it will get really easy from here onwards. There are three possibilities, major possibilities, three reasons for functional dysplasia. The one is achalasia cardia, or it can be diffuse esophageal spasm, or it can be nutcracker esophagus. These are the three DD of motility disorder of esophageal dysphagia. Okay. If I have to tell you what is the most common functional cause of dysphagia, it would be achalasia cardia. Okay. What would be the
Yes,
most
sir.
common cause of functional dysphagia? That would be achalasia cardia. If I have to tell you what would be the most common functional defect, that would be nutcracker. You see, these are 2 points. You have to get with me in this. Any functional defect which will lead to a patient having dysphagia is more common achalasia cardia. But more common functional defect may be present, maybe the patient is asymptomatic, but more common functional defect is nutcracker esophagus. Okay?
Yes, sir.
Any confusion? This is the
Sir,
most
most
common functional defect. This is the most common
uh,
functional defect leading to dysphagia.
okay, sir.
Okay?
Yes,
I
sir.
can write it, or but I don't think it's not writing. का है. So I will ask you to have a table like this: DEC, AC, DES, and nutcracker. So we have to differentiate between these three. हमारे पास ये three, we have three possibilities now. So I will ask the patient profile complete. Okay, the patient has told me this story till now. Dysphagia few seconds after swallowing, and I am feeling tightness in sternum. Okay, and I have suspected esophageal dysphagia. Based on that, I have now three probabilities of functional dysphagia. I have to rule them out. So I will ask more questions. I will ask, if the dysphagia is to liquid and solid both. If the dysphagia is to liquid and solid both, or more preferably, I will ask if it is for more liquid than solid. The patient will tell me, sir, I can eat dry foods, I can eat fruits, but I am not able to drink water. I am not able to drink. I can eat, but I am not able to drink. I am having difficulty in drinking things. Or it can be both, but there will be always liquid first, then it will aggravate into, sir, I used to eat but not able to drink. I was fine with that. But now I stopped, I am having difficulty in drinking, and after 3 days now I can't even eat solid food also. Any profile, any of these three profile, if it is saying that is characteristic for functional dysphagia. Okay. If a patient comes to you with a profile liquid getting more affected, liquid or solid both getting affected, or liquid first, then your answer would be, okay, sir, this patient might have a functional defect or a motility defect of dysphagia. You understand this?
Yes, sir.
Okay. And clinically, most common would be achalasia cardia until proven otherwise. Okay. Until proven otherwise, kya? If achalasia cardia, then there will be two more features with it. One is it will be a type of progressive dysphagia. That it started few days ago, it was mild, but now it is getting much more severe. In achalasia cardia, the profile will get more progressive with time. Okay, the patient age would be around young, and it would be a female more preferably. Then this point towards achalasia cardia. Okay, this can be a progressive or this can be a non-progressive also. I'm not saying if there is no non-progressive, that may not be achalasia. That can still be achalasia, but it will be a fixed non-progressive. It will not be relieving. There will be no relieving history. It will either be fixed or it will either be aggravating. You get my point?
Yes, sir.
Okay. So there are some associated questions you have to ask. Is there some kind of halitosis? What is halitosis? Can you explain? We have discussed
Bad
it
breath.
before. Bad breath. Good. Is there any nocturnal cough? Are you having a cough in night problem? At night, do you have cough problem? Do you feel any kind of pain behind the chest? Retro, sternal, pain history. You would look for this question. And of course, you will on examination. You will look at dental enamel. Why I am looking at dental enamel? To confirm my suspicion of halitosis. Okay. If a patient, female patient, a 30-year-old female comes to you with a complaint of dysphagia more to liquids, she also have bad breath, complains of coughing at night, and she has to wake up, due to which she is not able to sleep. On asking, is there something else, she said she sometimes has pain episode in her center of chest. On examination, you found that enamel erosions in her mouth. What would be the diagnosis? It's a case spotter. You know how the case will be there. The answer would be achalasia cardia.
Cardia.
Is this fine?
Sir.
Hello?
Yes, sir.
Okay, okay. Let's say the profile is this liquid, liquid, and okay, liquid followed by liquid. And the patient says, I have another complaint of chest pain. I will still think of achalasia. But chest pain with intermittent dysphagia. What did I say now? Intermittent. In achalasia, either it is aggravating or either it is fixed. It was not getting relieved. But if she says, if he says, if that patient says, okay, I am having a dysphagia, after a few seconds, I am feeling something, food stuck behind my sternum, we will come into esophagus real. Now I ask, okay, liquid or solid? Then this is okay, liquid. Does any point of time do you feel okay, I am getting relieved? And he said, yes. It comes only episodically. It is not progressive. It is not fixed. Then it can be either DEC, DES, diffuse esophageal spasm, and nutcracker esophagus. Okay, you know how to differentiate this at this point in flowchart.
Yes, sir.
Okay, what is achalasia cardia? Okay, let's discuss a little bit about achalasia cardia. How achalasia cardia, little theory here. You need to know about achalasia because they will see what is the achalasia cardia. I will give you one definition of single line. Each and every word is important. It is a selective loss. It is not a generalized loss. It is a selective loss of what? Of inhibitory myenteric neurons. It is a loss of selective loss of which type of myenteric neurons? Inhibitory type of myenteric neurons. If there is a loss of inhibition, that means the system will be very stimulated. You okay? If there is
Yes,
loss of
sir.
inhibition, then the system will be stimulated. What is the system here? Myenteric plexus is the nervous supply of esophageal system. esophageal system, it is a nerve supply of peristalsis. That means there is loss of innervation. That means the contraction will be there for a
More.
prolonged time. Okay. Menintric neuron in or back plexus. Okay. What does these inhibitory neurons secrete? Who secreted two enzymes? Nitrous oxide and vasoactive VIP. These two hormones, the inhibitory neurons were using these two negative neurotransmitters. Okay, if this is gut, if I have to tell you about a gut, simple theory, this is a physiological concept. This is our food bolus. In peristalsis, there would be some factors which is pushing, and that will lead to contraction of the serosa or the pipe from behind, and there will be some factors which are relieving, that will lead to dilation of the esophagus. Those factors which are relieving, those are relieving are two, NO and VIP. These both are inhibitory neurons. These are the inhibitory neurotransmitters which relaxes the esophagus. I am saying these are absent. What will lead to in achalasia? The pipe will get
Constriction.
narrower and the food will get stuck here. This will lead to achalasia. Okay.
Yes, sir.
This is a very important definition. You need to have, each and every word is important if you want to ever appear for NEET. This is the, or any diagnostic protocol. They will ask the heck out of achalasia cardia if you have got a spotter there. Simple. DEC and NC I won't explain much, but this is the theory part. Okay, this is the clinical profile we have discussed till now of the functional. Okay, sir, I have discussed the clinical profile, but still, I need to have a concrete objective thing. I need an objective proof. Ki, okay, it is AC, it is DES, or it is nutcracker esophagus. Okay, I am with you, man. I am with you. I will do a barium swallow. In dysphagia, the first investigation you do is what? Barium swallow. This is the first investigation we have done in when the case was Zenker's diverticulum. I am doing it again. In barium swallow, in achalasia, I will get a finding called as bird beak appearance, or also known as pencil tip appearance. Okay. If it is normal, I don't see anything on barium swallow. That is nutcracker esophagus, NC. Or if I see corkscrew pattern, corkscrew appearance, then it is DES. Is this clear? Now I have
Sir, in
diagnosed it.
nutcracker, how it is, it's a normal.
Nutcracker is actually a functional defect. The thing is, it is the most common functional defect. Na?
Yes, sir.
Nutcracker may either the esophagus will be very hypercontractile. See, this in nutcracker esophagus, it is a hypercontractile esophageal stem. Whole esophagus gonna contract. Let's say whole esophagus is contracted. After some time, whole esophagus will be relaxed. If there is no such kind of wavy motion, the food cannot go down. This is normal. This is nutcracker scenario. No way food can come here. Food is there, food is there, food is there. To make the food motion, the the esophagus in the front of food should relax. This is the normal. The esophagus in the front should relax, and from behind there must be contraction. This is the quiet pairing. Okay, that's how food moves. You understand? But in nutcracker esophagus, what is happening? Either all are contracting, either all are relaxing. You see my point?
Yes,
If
sir.
there is a stone stuck in pipe in your garden, how will you take the stone out? You will push from behind the stone and try to relieve from the front end. That is exactly how food moves. But if you try to contract the whole pipe, or you will either release. Will the stone get out ever?
No, sir.
No. So that's how nutcracker esophagus is there, and that's how, if it's a simple analogy how the peristalsis move. Put a stone in the pipe and try to make it move. You have to push from the behind, and the stone will move forward. If you start pushing whole, the stone will be there. You have to have a push from behind and relaxation from the front. Okay. Okay. I said,
Yes.
okay, barium swallow, you have done it, but it is not sure now what would be the result of this. I'll show you how this appears. 1 second. Yep. You see, this is rat tail appearance. This is our esophagus. Okay. This is like a small tail getting this. This part is contracting. I'm not saying this part is contracting. This part has contracted but failed to relax. There is a difference between two lines. One is this part is contracting actively. No, this part is contracting and it has failed to relax. That's why it has this kind of structure, which is a rat tail appearance. Similarly, here, this is our esophagus. This is our pencil tip. You know how sharp it is at the end. This is rat tail appearance and this is pencil tip. Clear?
Yes, sir.
Okay. This is mm, okay. No, I have to delete it. Yeah, this one. This something like this. Where is corkscrew pattern? You can see the esophagus here. Can you visualize the esophagus?
Yes, sir.
Corkscrew. If I have to draw it like this, isn't it in shape like this, like the DNA shape? This is like a corkscrew. I am corking a screw. Okay. I'll put a better image. Let's not. This is not a good image. But you understand the concept, how the corkscrew is there. In the notes, I will put the actual image or really understandable image. In the NC, it will be either contracting or either completely relaxed. So the esophagus would be normal. This is the one you should focus on. This is the one you should identify in a spotter if ever comes. Okay. But sir, based on brain's barium swallow, I can't do that, sir. It may be there, it may not be there. What would I do? Please help me. So the next thing the teacher says to me that, okay, you have to do what? It is a contraction problem now. It is a contraction problem and it is a problem of what happened? My screen stopped. Very. 1 second. Give me 1 second. How are there four participants? Hello? Now I'm audible, no?
Yes, sir. Audible.
I'm really sorry. Okay. But sir, I have come for you, barium swallow. What should I do next to get my confirmation clear? Either it is AC, either it is a DES, or either it is nutcracker. I say it is a game of pressure. I am diagnosing what? Functional disorder, which has a peristalsis. It has a contraction problem. So I will do manometry. What I will do is I will do manometry. What is manometry? Manometry is actually pressure studies. I will check the pressure of esophagus. Okay.
Yes, sir.
Yeah. One second, Dr. Aditya, we will extend the class 5-10 minutes. It doesn't matter. Please, you can join again. I am exiting all. Okay. Try to join again.
The same link, sir.
Yes, yes, same link.